Hello friends, today I'll be talking on this new update, 15th journal update. So this is on post-COVID, what is the new normal? So that is the topic. So we have had a roundtable meet with illustrious panelists just couple of days back with Dr. Ramakrishnan, Dr. Anup, Dr. Deepak Govil, Dr. Shiva Kumar, and Dr. Pradeep Bhattacharya and few others. So basically to look at what is the horizon as new normal in next 3 to 6 months. So what are the changes that the world would witness in the healthcare? So to that effect, most of the discussions that we did in the roundtable meet was derived from this particular paper that came in JAMA on 4th May 2020. So what are the choices that we would have for the new normal? So once COVID, intra-COVID or post-COVID, so what is the new normal that we would be facing? So the premise for that is to just reflect on how this small little virus has had a impact on the human lives. So they have just looked at the genetic components of the virus. There are only 15 genes in the COVID-19 virus versus 30,000 genes that are present in the humans. So just the 15 genes versus 30, it has really crumbled the human race. So that is the preamble the authors describe. So so there are different dimensions of our healthcare which tend to get modified and affected with this new COVID. So the first dimension would be this virtual care. So the virtual care is something that has really taken off after this COVID because really the whole philosophy is to have social distancing and minimize the social interactions to as much as possible to prevent the spread of this infection. So virtual care has become the norm in this setting. And so what has described is the frequent healthcare visits has been found to be unnecessary based on the new evolving trends from the patients seeking health benefits or health advisors on a virtual platforms. So it has been realized that the frequent visits for routine visits is something that was found to be unnecessary and maybe unwise. So the understanding is this pattern or the trend may tend to continue. The virtual healthcare or the telemedicine or tele ICU or tele rounds, what we call, is here to stay, and this may tend to continue. And it is clearly described that the social proximity does not equal to physical proximity. So basically, the social proximity or our social relationships can be maintained on a virtual platform of any nature, and not necessarily that means that we need to have a physical proximity to achieve that social interaction. So that is something that authors have reiterated. And what has been disturbing is this whole concept of telemedicine or tele ICU or tele rounds started almost 2 to 3 decades before. But because of whatever reasons, this whole telemedicine had not taken off, and the regularization or formalization of this process of telemedicine had not really happened in a robust way for last 20 years. And this telemedicine is taken a new role in even looking at self-care at home for elderly people or for vulnerable people. And there is been the elderly people especially, they are dissuaded from going to the hospitals because of their vulnerability, and telemedicine is reaching out to these elderly vulnerable people for self-care to happen at home through guidance. And not only it is limited to that, even all the educational programs that we are seeing or the training programs, it has been realized that this can be achieved with these virtual platforms or tele platforms. So that is also a new evolving trend that we have seen. I'm sure all the listeners would agree that since the onslaught of this COVID, we have been seeing umpteen number of educational programs that are typically happening in the virtual platforms, and it has been at least 3 months before even we have interacted on a social platform with physical proximity to embark on these educational process. And to summarize about this virtual care, so the authors conclude that the high quality help and the high quality advice and the high quality care can be achieved on the virtual platforms, at a much lower cost and at a much greater speed, because the healthcare is reaching to a patient at his place at a time that is agreed upon. So which means there is lot of logistics which can be circumvented to achieve this healthcare delivery, which has been realized with the virtual platforms. And to that effect, I'm sure some of the listeners would know that we from Columbia Asia Hospital, we are doing tele rounds for 14 district hospitals. So in Karnataka, ordinarily where the expertise may not be available to this district, so we have realized our physical presence may not be needed to help these patients with whatever advice or whatever help or whatever medical suggestion that would be needed, and this can be done on a virtual platform, and we have been successively doing this in the form of tele rounds. So in ICU we typically do a detailed handover. So this sort of a detailed handover happens twice daily on these virtual platforms, and the investigations, the clinical parameters, and the monitored variables are integrated on a virtual platforms, and the suitable, appropriate, timely interventions and advice of any interventions, be it diagnostic or therapeutic, are given on these platforms. And we have been seeing a great response. Alongst with this, alongst with helping the care of the patients on these virtual platform, what we have succeeded in our tele rounds model is we have been able to impart all the education and impart all the protocols and import any new updates in these tele rounds, which has been found to be immensely helpful in raising the standards of care and remaining on the same page and try to homogenize the care. I think this is what we have achieved in our tele rounds, where we have partnered with the government and we are conducting for 14 district hospitals. So the virtual care is here to stay, and it appears that this is only going to grow multifold to penetrate and improve the healthcare in various dimensions. So the second aspect of new normal is protecting the workforce, because friends, you would know that the priority of protecting the workforce was not there at all prior, was not a priority at least. So what this pandemic has made us realize is the workforce is at a highest risk of getting affected by this infection or by the circumstances, and the safety of the workforce had a very least priority prior to this pandemic. So what this pandemic has done is it has brought the workforce safety into the forefront, and it has put it at a much higher priority. And this has led, and the protection of the workforce was at high risk is realized that it is mitigated by adequate supply of personal protective equipment and by adequately preparing them. I am sure every listener here would know the hospitals across India during the lockdown period, the whole effort from every healthcare organization had been to protect the health force by procuring adequate number of PPEs and to keep the healthcare prepared about the precautions one need to take to defend themselves against contracting this deadly virus. And so the new normal what has created is put the safety and protection of healthcare as the top priority, and it also involves a lot of emotional support to the personnel taking care of the patients in the form of hospitals providing free meals and taking care of their needs and protecting them if they are exposed by quarantining them within the space which is established by the hospital. So these are some of the newer nuances that has evolved from this pandemic. So the protection of the workforce has taken a priority that includes empathetic emotional support also, which goes hand in hand in taking care of this workforce. So that's a new normal, and we believe this normal would continue until this pandemic is fades away. So that is the second. So the virtual ICU or the virtual care is one aspect. Protecting the workforce is the second domain. The third domain is the speed of learning. So this pandemic came as a blitz, and countries did not have too much time to prepare themselves to tackle the pandemic. So the need of this hour was to adopt certain practices at a lightning speed to tackle this pandemic. So ordinarily, if you see the proven and favorable innovations to help a disease condition, to help mankind, typically takes many years, and the average cycle time to come up with a new modality, new innovation or new therapeutic modality to be conclusively proven to be helpful to the patients takes approximately up to 17 years. So this is come from this US study. So which means it takes such a long time to establish a innovation or a therapeutic modality or a diagnostic modality as a proven benefit to the patient. But what this pandemic has done is, so this pandemic has pushed the scientists or the scientific community to the wall to come up with innovations, to come up with therapeutic modalities in a very short period of time. So the speed of learning mandatorily had to be intuitively significantly increased. And one such example, see, ordinarily setting up of a hospital of this scale, the Nightingale Hospital that was set up in London, which can accommodate 2000 odd patients, ordinarily would take many years. But you could see, because of the need of an hour, this particular hospital came within 18 days of planning, and the first patient was admitted in this hospital within 18 days of conceptualizing of setting up this hospital. So this was a typical example how the speed can achieve certain envisaged result or envisaged goals that one would have in mind. And in USA, typically the guidelines would take somewhere from months to years for any specific guidelines for a certain disease condition or health condition. But in this pandemic, these guidelines were rolled out within weeks to homogenize the care. And if you look at Chinese, so 73,000 patients were evaluated to determine the risk factors, and this happened in weeks. So what we are trying to say is, so this disease has led people to come up with solutions in an extraordinarily short period of time. I think that is what we call as speed of learning, which had to increase at an exponential speed to come up with solutions for the problems we had in mind. And not only these, the biomedical companies, the startup companies, and the universities were coming up with innovative solutions to establish diagnostic modalities for this pandemic. And these biomedical companies and universities were working in tandem to come out with any new antiviral drugs. And you have heard of this remdesivir, which is big trials are happening and the results are being published in a lightning speed. So we are looking at solutions of this nature, and they are working collaboratively, startup companies, universities, and biomedical companies, to come up with solutions. And I'm sure all of you here would be hearing about the race in coming out with a successful vaccine from different continents across the world, be it Europe, be it Asia, or be it Israel, or be it America. So all of them are working collaboratively to come up with a vaccine to find a cure for this disease. So that is the third dimension, where the situation has led to intensify the speed of learning or galvanize the speed of learning. So the fourth dimension of new normal is value of standards. So what that means is, the so-called physician or the doctor community have become less tolerant to unwanted variation in the management standards for these patients. And the physicians have been led to ethical dilemmas, especially when it involves rationing of admissions or rationing of ventilators. So these are some of the problem areas that has evolved, and physicians want a bit of a clarity on these dimensions. And the new normal is, most of the specialists, doctors, or the healthcare personnel are looking at standard clinical processes. So they do not want to deviate from the standard operating procedures set up by the institute or hospitals, or standard clinical processes. So the simple example is, uh, once this COVID has set in within my own hospital, I would say that the triage areas were set up, and every doctor was mandated to follow certain protocols, be it the entry point to the hospital, be it following certain lifts and avoiding certain lifts, and donning of all the PPE gear when you are dealing with the triage patients. So these are something which is happening in an automated mode, where every doctor is mandated to follow certain policies or protocols that are laid out by the government or by the institute or by the organization, and their ability to unleash their autonomy in these things have been subdued or mitigated. So that is something which is a new thing, which means every medical care worker or a healthcare worker is mandated to follow certain set processes that has been put in place, and is dissuaded from exercising his own autonomy to breach these protocols. So that's a new thing that has happened. And the strangeness about this whole COVID pandemic is even the experts, the so-called, it may be a super specialist cardiologist, it may be a nephrologist. These specialists are seeking out for the right guidance in how to manage their patients, and guidance from the approved organizations to, and seeking their help to ascertain how to manage their patients in an appropriate way. So this is a unique feature that has evolved from this COVID pandemic. And so when I say value of standards, like the specialist, every healthcare personnel is looking up to some sort of a protocol guideline that is coming out from a responsible apex authority. So in US, from 11th March, they set up a National Academy of Science Standing Committee, and within 1 month, the standing committee came out with 11 formal rapid expert consultation documents, which means there is a rapidity and a urgency in the need of these documents, because every healthcare personnel is looking up towards certain document to be followed, so that this disease can be tackled, and they can win this battle. So this is a new phenomena that is evolved, that collectively, as one cohesive force, the healthcare personnel are looking at following the approved documents that come from an apex body to tackle this disease. So the individual autonomy is something that they are not really they're not really paying much attention to, which is a good thing. So the another big question in the value of standards is about the global education. So what has happened in this new pandemic is, there is a inter country or global interconnectedness that is happening by sharing the knowledge across different countries, and that I'm sure every listener here would know. We are typically doing this by collaborating with every country to share their experiences and learning from their experiences, and taking necessary steps to minimize the morbidity and mortality by adopting such experiences that others have been having. So global interconnectedness is something that is a new phenomena that has happened. Collectively, countries are working together to tackle this disease, and there is a shared knowledge that is happening across the borders, which is again a new entity. And so there is no protocol which says it is very unique to one country. So people are exchanging ideas, and protocols are changing in a dynamic way based on the shared knowledge or shared education or transfer of knowledge that is happening. And the new normal is everyone is looking out for an authentic sort of a protocol or a guideline or recommendation from a trusted authority. So these are all the new normal that we are witnessing in this pandemic. And the whole intent of this global interconnectedness, shared knowledge, and trusted authority, with a primordial intent. Every country is committed to reduce harmful, wasteful, unscientific variation in the practices. So here, the whole globe is working as one unit to see what is the best sort of a therapeutic modalities or diagnostic modalities or preventative modalities one could adopt to tackle the burden of this pandemic. So this is again a new norm that has evolved with this pandemic. So that was the fourth dimension. So the fifth dimension is the preparedness for threats. So what this pandemic has shown is that public health, which was predominantly meant to uh, the address the preparedness for tackling this pandemic, so they have realized world over, so the public health has not raised up to its standards to tackle this pandemic. And this is in the Western world. They have realized public health had eroded, and there was a lack of readiness from the public health. So I'm sure this applies to our country also. So there was not the expected level of readiness or capabilities to tackle such a pandemic. And worldwide, what has been noticed is the public health has paid a heavy price for the toll that this COVID virus has taken on the human mankind. So this is something that they have realized. So again, there is a renewed emphasis on strengthening this public health and keeping them well prepared, and providing them or equipping them with adequate resources to tackle such future pandemics. So the whole emphasis is again moved from tertiary care or a binary care, healthcare support, to more emphasis on public health, to take preventative steps and tackle these pandemics at the outset, and not allow subsequently to to have a huge toll on the human mankind by such virus or by such pandemics. So that is a fifth dimension. The sixth dimension, what this pandemic has highlighted, is inequity of the care. So which means there is a heterogeneity in the care provided, and this has happened even in a developed country like US. So they have found that the mortality of COVID, surprisingly in US population, was found to be much higher in poor or underrepresented minorities, and mortality was found to be high in marginalized sections of people, and this has happened in Europe and in America, and mortality was found to be high in indigenous people. So this is really troubled or very disturbed. This has been the disturbing finding from the US data, that the care, there has been inequity in the care that is provided to these lesser socio-economic sections of the society. And if they looked at the data in Chicago, 30% were blacks, and they found the COVID-19 deaths, 68% deaths happened in these blacks. So again, there is a disparity uh, between the care that is provided to these marginalized sections. And even the same trend was found in Wisconsin. So if you look at the population of Wisconsin, it was 6% were blacks, but the 50% of deaths happened in blacks. So which means there has been a disparity in the possible care that was provided to these marginalized section. So which again highlights, I'm sure this may be happening in our country as well. So this is something which has to be looked in, because in the time of crisis there should be equity in the type of care, or distributive justice has to be maintained, and that complies to our ethical principles of healthcare, which was lacking in COVID. That was highlighted. And the questions from this pandemic has risen whether our leaders, national leaders, or our country leaders across the world, whether they are directing the population and by to directing to establishing durable and generous social and economic safety nets. So this is something again which we have seen time and again. Uh, so when you try to balance the lives, so what has happened is economic deprivation and economic suffering has happened into the lesser sections of society or marginalized society. So whether the leaders have provided adequate safety net, economic safety net or social safety net, in reducing the stigmatization and taking care of their economic needs in marginalized section, whether leaders are committed for this, that has been questioned with this pandemic, that we are seeing in India, because we had an issue with migrants who suffered a great ordeal in this pandemic, because there was no preparedness to support these migrant workers with the economic facilities or economic support. And even social support was something that was very much needed for patients and their families who are inflicted with this disease. So this is something where leaders also were caught unprepared, and this raised serious questions about leaders' commitment to create safety nets for economically or socially or psychologically. And so what has been also shown in this pandemic was the public have suddenly their perceptions have changed. So they are now looking at the scientific evidence that is going to help them tackle the disease, and they are looking at the sound scientific principles which should influence their defense against this disease. So that is something which again is a new thing that has evolved. And another new thing that has evolved is the social solidarity. I'm sure you have seen there is a renewed sort of a respect and adoration for people who are working during this crisis, which includes healthcare workers and police, or the delivery boys, the food delivery boys like Swiggies. So they have found renewed respect and adoration, and there have been an applause for all these people, and they are looked at as heroes. So that is a new phenomena that has emerged from this pandemic. So that we call it as a social solidarity, which is a renewed sort of a dimension that we have witnessed. And what this has also shown, this pandemic, is worldwide there has been reduction in the motor vehicle accident deaths or road traffic accident deaths, and these motor vehicle accident deaths constituted third leading cause of death worldwide, and to a large extent this has been significantly reduced with this new pandemic. So these are some of the positive attributes of this pandemic, where the social solidarity has set in and there has been reduction in the motor vehicle deaths. And what has been increasingly seen is exponential increase in the usage of these virtual platforms like Zoom and online trade or online purchases has increased multifold, and FaceTime. So, as I said, social proximity is maintained mainly through these platforms like FaceTime or any other apps of this nature, and physical proximity is definitely come down because of this pandemic, which was the need of the hour. And what is also been noticed is there is a significant reduction in the carbon emission from the Earth, and this has been looked at as a more healthier celestial body. So this also is a because carbon emissions were progressively increasing over many decades, and just as this pandemic in last 3 months has had a significant effect in reducing the carbon emission from the planet. So those are the six dimensions that has been deliberated upon in this manuscript, and we deliberated in our roundtable meet as well. So the conclusion is the new normal that we are going to face is not going to be influenced by the fate, but rather by the choices that we make. And what has been important is the science and facts. The science and the facts has been put at a much higher pedestal to guide the resource utilization, which is a good thing, which is a new thing that has got renewed emphasis on. So the science has got a renewed sort of a recognition put on a higher platform in guiding the resource utilization and in guiding the behavior of the population, because we understand now most population worldwide would be aware of wearing a mask, and most population worldwide would be aware of good hygiene, hand hygiene, and most world population would be aware of the importance of social distancing and avoiding crowded places. So this is a behavioral change which is influenced by the science and fact and not by ad hoc belief system. And the solidarity, the question still remains the renewed solidarity, the social solidarity, where people catering for these healthcare workers, or be it police, or be it the people who are working during this crisis, this solidarity, whether it will stand the test of time after pandemic, that needs to be seen, because right now the solidarity has been established. Whether the solidarity will continue with the time that is going to evolve is something that needs to be seen. And there has been a good amount of compassion and empathy that is being shown to the suffering population. And again, it needs to be seen whether this sort of a compassion and care would continue with this passing away of this pandemic is something that needs to be seen. And I think what this pandemic has done is this whole world was very much burdened with this emphasis on financial aspect. So the commerce. So that has really taken a break. So the whole world of commerce has taken a break because this pandemic did not allow any of these commerce activities to continue. So that, and this has led to tremendous reduction in the stress amongst the population. So this can be looked at in a positive note. The whole materialistic sense that was prevailing in pursuing the materialistic needs and revolving around the commercial aspect of it. So there has been a break, and this has led to reduction in the stress amongst significant sections of society. So which is also one of the positive attributes. So finally, so this world has taken a break from obsessive focus, and the obsessive focus was on more on near-term gratification. And this pandemic has led to the world to take a break from this obsessive focus on near-term self-gratification. And this pandemic has prepared the world better for subsequent threats that may evolve uh, due to various other reasons. And this pandemic has led world towards fair and compassionate redistribution of wealth. So that is something, because you have seen US flushing trillions of dollars and India flushing lakhs of crores to support these marginalized sections of society and support them financially. So there has been redistribution of wealth that has happened. And most importantly, this pandemic has has raised the alarms to the world to take care of the security needs and to create an opportunity for all to survive during this raging pandemic. So I would end with this interesting graph that came out. I think this will be useful. This came I just saw in one of the circulation. So as you see, any patient who comes to this stage after first week where they start needing oxygen, that is where it is identified that they tend to develop the cytokine storm, because your viremia is coming down, but your inflammatory response peaks when your oxygen saturation is coming down. And all the interventions are recommended during end of first week, where the patient starts needing oxygen to maintain saturation. So that is where awake proning and the possible role of steroids and possible role of NIV and possible measures to minimize progression to multi-organ function and possible role of anticoagulation to prevent microthrombi is advocated at this stage, maybe after the first. So any patient who starts to need oxygen after 1 week, I think that is the time when inflammatory cascade is setting in, and that is where these interventions has to be thought of, is what is emphasized in this graph. So thank you very much. I would end with this nice quote by Albus Dumbledore, who said that great knowledge is attained with great pain. So whatever knowledge we are gaining with this COVID is being attained with a lot of pain and a lot of loss of lives. So thank you very much. You can visit my website www.drpradeeprangappa.com to rehear to this lecture and gain clarity and insights. Thank you.